Okay, so welcome to the Young Dementia Network webinar. I'm Tessa Guttridge, I'm a Young Dementia Network Chair. We're continuing our series of addressing different issues to do with diagnosis. And in particular, today we're looking at a different service model, which is one of the things that previous attendees asked us to do. There's a huge variability, isn't there, in terms of diagnosis, assessment, support offered to people with young onset dementia across the UK, and ranging from dedicated support services, being part of an all-age team, and then sometimes very little that's appropriate at all. Today we were looking at the Young Onset Dementia Service in Doncaster, and we're welcoming Dr. John Bottomley, who's lead for that service, Associate Medical Director and Consultant Psychiatrist at Rotherham, Doncaster and South Humber NHS Foundation Trust. And John's going to talk us through the sort of nitty-gritty of how the service works. So a big welcome to John. We've allocated some time for you to pose questions, and would recommend that you use the Q&A function for that, so that we can pick them out easily. But of course use the chat for all else. That would be great, and we'll be popping some useful links in. Before we hear from John, though, let's listen to Michael and Catherine in conversation. Michael Booth was diagnosed fairly recently, actually. He's living with young onset dementia, and Catherine asked him about his experience of diagnosis in particular.
So I'm really pleased to be joined here by Michael Booth. Michael was diagnosed with young onset Alzheimer's at the age of 46. Since his diagnosis, Michael has become involved with a number of different organisations to raise awareness of dementia, and is passionate about changing the view of dementia and young onset dementia. Michael is a member of our Young Dementia Network Steering Group, and thank you, Michael, for joining us today. So during this webinar today, Dr. Bottomley is going to give us an overview of the young onset service that they have developed, and how they provide support to people going through the process of diagnosis and the support beyond that diagnosis. So would you be able to tell us a little bit about your own experience of diagnosis?
Yeah, sure. My diagnosis started with, has to go back about 10 years ago with my mum. She was diagnosed with young onset dementia. At a later stages of her diagnosis, I was doing talking to the mental health team that were helping with my mom and the care, etc. And they noticed some of the signs. I was repeating questions, asking same things, missing things that they'd said, etc. And so they had suggested that I go for a test. So if it wasn't for the vigilance of them, I'd probably still be struggling even today. The problem came in that even though they made recommendations to the GP and the neurologist, because of my age, being 46, actually it was about 44 and a half at the time, they didn't buy it. They just kept saying, you know, you're too young, it's not the case, it's not genetic, there must be stress, etc. So there was actually more of a ding-dong, an argument between the mental health services and the GPs and neurologists, and this went on for some time. Anyway, I did the MMSE, is it the MMSE test?
Yeah.
The memory and cognitive evaluation thing, and they found a score of 64 was what I scored, showing that there was a problem. Even then, the GP said no, so I insisted on going for some scans. Mm-hmm. I went for a MRI scan first, and that was slightly inconclusive, though they said there is something not right. So from that, I then went to a PET scan, mm-hmm. Which, if anybody's had it, will know is quite a daunting thing where you're strapped down and told to not move for 10 minutes, not even your feet or your toe, or just, which is rather hard when you can't remember quite why you're there all the time. So it becomes a bit of a problem. Anyway, that was then what diagnosed me with young onset Alzheimer's, along with then another memory and cognitive test. So it was quite, yeah, even the feud was interesting to see between the medical services of how to go about diagnosing somebody with Alzheimer's or any other form of dementia. It was quite eye-opening. My mom's process took 3.5 years to diagnose, and that was just extremely frustrating trying to go through that with her. And then to see how medical staff some 10 years later had not changed their view.
You still had the same issues.
Was the same issues all over again. I just thought, I can't be tuned with this.
Yeah, I can imagine.
So it was just, eventually it was put your foot down, this is what I want, and this is what I would like to be done. At the worst case scenario, rule it out rather than rule it in if need be. But as it was, that was the diagnosis anyway.
So how do you think that experience could have been improved for you? I mean, you said there it's a lengthy experience, the difficulty at the beginning with the GP.
I think more understanding about the diagnosis process, specifically by various clinicians. I think that's really important. And to take advice from other clinicians at the same time is worthwhile doing. To understand as well the impact that it has on me, and then also the family and friends around it, because it's not just about me, it's about them as well. And more care and guidance. Once given the diagnosis, all I was given was a whole load of leaflets, no direction to support, nothing. Fortunately for me, because of caring for my mom, I understood what was coming. I understood the process. I had a lot of dealings with people such as yourselves, etc., with dementia. So I had a better understanding. But when we were dealing with my mom, we had nothing. And if it wasn't for me doing research and trying to understand and follow, you get nothing. And then to try and get help from social care and social services, you just seem to slip in the crack as young onset. You don't fit either side because of your age. So there was just problem after problem once you've got your diagnosis. So I think better understanding and care, I think, is really important. Take age out of the equation. From a medical point of view, it is really important. Don't just, you can't have it because you're too young.
That's what needs to stop, so that people recognize and raise the awareness that it's possible to have dementia at any age, not just a disease of the older people. So what changes would you like to see in terms of the experience of diagnosis for people with young onset dementia and their family members too? As you said, they are a key part of that diagnosis process.
The first thing I think needs to be done is, from a medical point of view, is to take age out of it, but also to recognize that young onset dementia, any type of dementia, is a disease in itself. It comes with its own set of problems unique to anybody else who's diagnosed. And then I think to be more compassionate and understanding. One of the other problems that was always an issue is that it takes so long to get appointments. With a cancer diagnosis, you're given quicker appointments. It's set within a certain criteria set by the government. I think that needs to be done for dementia and for other types of neurological diseases as well. So having quicker appointments and sticking to them. It's so frustrating. You get everything prepared and ready to go for an appointment, and then you get a phone call. Oh, it's been cancelled. It's going to be moved now to sometimes 6-7 months. It took me over a year, I think it was a year and 3 months, to go see a neurologist just to confirm the whole diagnosis process. It's like, why does it take?
Waiting in that time, you can't.
Why does it take so long? And in the meantime, you've got your GP saying you're too young. You've got your friends and family not believing that there's something wrong. Some of them very supportive, others just disappear. So all of those additional things that are thrown in the pot as well. So all of that needs to change. A better diagnosis delivery is very important.
Yeah.
Once you're given your diagnosis, get support. Be pointed in the right direction of where you can find that support, who you can go to as a point of contact. Access to a psychologist, I think, worked very well for me. Again, because I had the access to that team, I was able to get in and speak about things for me and for my wife, which was very important. We could talk things through. Having access to people who are diagnosed, or if you're a carer, having access to somebody going through the same thing, so that you can talk things through, I think is vitally important to see that, okay, you've been given the slap in the face of a diagnosis, but you can still continue with, you just got to learn to adapt. Speaking to people who do, or who can help you to show you how to adapt, not to get frustrated all the time when things you would take as bread and butter in your life, such as your speech or your remembering to drink, just how to adapt to those and to see that it's okay, you know, it's part of the process. There's no point trying to fight it, but you can deal with it. And I think those are things that I think are vitally important, just having access to those things, but also then care and understanding from the clinicians of what you're going through.
Giving that hope at the time of diagnosis. You know, we keep hearing that word hope, but it is so important. It
is very important. But then showing where they can go to get that, and how to deal with it, because there's no point just saying, you know, here's what you've got and then off you go. It's just, that doesn't work.
Well, thank you. I think what you're doing, Michael, by sharing your experience and your advice and your knowledge is really, really important for us to hear today, and for everybody listening to the webinar to hear the experience you went through, and to the advice you can give us to help try and change that, improve that. It's really valuable to hear that. So thank you very much for sharing your experience.
Pleasure, Catherine, and thank you for having me.
Thank you.
Thank you.
Michael's experience, unfortunately, is reflected with many of the people that we're in contact with, but he has some great advice there, doesn't he, in terms of adapting, in terms of seeking compassion and care, and the support and connection with peers as well. So let's now hear from John, if you could join us, John. To see a service in practice in terms of the diagnostic assessment and support is offered.
Hello. Hopefully you're seeing a presentation. Tessa.
Yes, thank you. That's fine.
Oh, great. So thank you for allowing me to talk about things today. In terms of what Mr. Booth was just describing there are a few things that I'd absolutely echo and would want to point out that we've reflected upon in Doncaster. We're blessed by having a very active patient groups and carer groups who will very vocally and helpfully instruct us on what is useful and what's less useful in dementia pathways in Doncaster. So just in terms of how things are in Doncaster, we're looking at a population of a bit over 300,000. 20% of those are adults, 120 of them are children or young people, so it's about 40% are 34 to 65. So we're looking at a population of about 120,000 who we think are at a higher risk of young onset dementia. And would want to be attending to. We get about 200 to 250 referrals a year. We assess about 150 people a year. So we've got 150,000 who might have dementia if we're taking it down to age 18. and we assess 150. We're assessing every year about 1 in 1,000 adults in Doncaster. So it's a high proportion of the citizens in Doncaster, 1 in 1,000, will be assessed for whether they've got young onset dementia or not in Doncaster. In terms of how many there should be, data would suggest we should have perhaps about 90 odd. We've got 170, so we believe we've captured probably most people or everyone in Doncaster who does have young onset dementia. I was asked by Dementia UK and through our network, I was asked to talk to 10 specific questions, so at least cantering through those. In terms of diagnosis, as Mr. Booth was just sharing, there can be a long delay in diagnosis that patients can experience. So we wanted to reduce that. So the diagnosis currently in Doncaster, before COVID and now since COVID, from referral to diagnosis, 85% of patients are diagnosed and are treated with medication and a care plan within 6 weeks. So the NHS England's target for dementia of all ages, of people being referred, assessed, diagnosed and treated by 6 weeks, we're able to, and we are meeting that in our old age service, but also in our young onset dementia service. So we are trying to deliver on that timely diagnosis that Mr. Booth was just talking about. The reason that we just generated our service as we have was mostly being pragmatic. And I'll talk about that for a moment. It's really looking at a pragmatic diagnosis where we're thinking, does a person have dementia or not? So rather than doing lots of complicated, expensive, time-consuming tests in neuroradiology departments or medical physics that we have, looking at isotopic scans and like, we really wanted to know for the patient and their family, does this person at this point in time have dementia or not? So we have an approach where we progress brain scanning. And again, MRI scans often are inconclusive because they're very good at looking at vascular damage. They're not very good at looking at atrophy for Alzheimer's disease. So our local radiologists favour CT brain imaging over MRI scanning. So we'll look at MRI scans for everyone referred with a query of a diagnosis of young onset dementia in Doncaster. And then we see them once for a home assessment that takes several hours as we're going through the history with the patient and with their family, and then doing an Adam Brooks cognitive examination. So that's 100 items on a cognitive test. So all of that does take a couple of hours. And then to document it all, it's pretty much a good day's work for each assessment. We see people in their own home. And again, that was at patient request as we're looking at tweaking the service. It's become much more efficient for us because although there is staff travel time, it means we have almost a zero DNA rate in contrast to clinic-based services that we have in our trust, in our memory services, where particularly through the winter, with elderly or young onset patients who have physical illnesses or inclement weather, we were missing a number of clinic slots. By closing clinics and seeing everyone in their own home, although there's a travel cost in petrol and staff time, it's actually increased our staffing, face-to-face contacts and our number of diagnoses appreciably by moving care close to home and keeping with the NHS England agenda, because we don't have any patients who don't attend the DNA rates. So by trying to do everything within 6 weeks, which mostly we are achieving 85% of the time, we have that initial assessment over half a day-ish with a patient and their family in their own home, and the CT scan. And the assessment's very much the history and the cognitive testing to operationalise whether the person might or might not have dementia. And we used these criteria. This is it's a free PDF that you can Google. This is the World Health Organization's international classification of disease 10th edition, the ICD-10 criteria that we use in psychiatry for diagnosing, well, all psychiatric conditions. But for dementia, it's set out for us here that you need to have a decline in memory and a decline in another area of cognition and change in mood or personality. And it needs to be in clear consciousness. You don't have delirium. And these changes need to be clinically significant, so impacting upon activities of daily living. And that's it. So we took that as our diagnosis of dementia. Do you satisfy these criteria or not? And if you do, you could have dementia. And if you don't, then you may well have forgetfulness. You may well have other problems, but blessedly, you don't have dementia. So rather than trying to have a very high-tech diagnostic service to try and work out what the cause of forgetfulness is, our commissioners and patients were very clear. We just want to cut to the chase very quickly and be able to look at large numbers of patients every year to answer a very specific question about, is there dementia, yes or no? And that's why we're able to be fairly low tech, having a CT scan, a face-to-face assessment with a patient, an adequate cognitive examination, and then with an MDT discussion, we've got the information to say whether dementia criteria are or aren't met based on that, without the need of neuropsychiatric assessments from psychologists or isotopic, the nice guidance suggests that you might need to do CSF, cerebrospinal fluid taps, and looking at high-end, very expensive tests to look at whether dementia may or may not be present. Our commissioners and our patients said, no, we're wanting a very much the opposite end of the spectrum, a pragmatic approach to, does my mum have dementia now, yes or no, rather than, if they don't have dementia, lots of tests to find out what it is. In terms of the offer, having been diagnosed, we then looked at the post-diagnostic support. So we don't use formal cognitive stimulation therapy. And I mean that in the pure sense of the word as nice guidance describes it, because I don't know of anywhere that doesn't do formal CST at the moment still. Certainly across the Yorkshire and Humber region, across our integrated care system, no one is using CST. And that's because CST is necessarily as an evidence-based treatment. The evidence base is for a very, very specific intervention, i.e. you will have 14 sessions over 7 weeks, and each session is 45 minutes. And in those 45 minutes, you deliver content according to a prescribed manual, and that's CST. And you don't do it in half an hour because that's rushing it too much. You don't do it an hour because people might not concentrate that long. It is a very, very prescribed treatment to do CST. And I don't know any memory service that's still doing CST to that model. So we're not a particular outlier in departing from CST. So we use the principles of CST, that we have psychosocial support from nursing staff, principally, and our support workers. And we have Fulwood Lodge, a bungalow that is essentially owned and managed by the patients and carers living with young onset dementia as a place for them to use in whatever way is purposeful for post-diagnostic support. Having had one contact after CT scanning for the assessment, the second contact is then in their own home again to share diagnosis and to share the post-diagnostic support, which invariably is within a week of the first assessment. So because we're only having 2 contacts in the patient's own home by a nurse and the CT scan, that's how we were able to scale it up to assess such large proportions of working age adults in Doncaster, and to do it all within 6 weeks. We then generate a care plan that is generated with the patient and their family, that will look at what their needs are. So that is incredibly varied. So we have one gentleman who wanted to go swimming. So we have a support worker who took him swimming and went swimming with him each week. We have another patient who wants to play pool, so their support worker takes them to play pool each week. We have other people who have ambitions around works, who want to go to the seaside and take their grandkids to the seaside. So we have very bespoke, personalised care plans to deliver person-centred care that is attending to what's important to the person living with dementia, to attend to their agenda. And that's so the care plan's generated with a band 6 registered mental health nurse, our community nurse and colleagues, and our support workers will then deliver on that, and that's both in a bungalow that we've got on the site or in the community. We'll also then think about formalised processes to support people through, such as it's a notifiable disease, so the DVLA need to be informed, but most people can continue to drive, so we'll support that. Thinking about lasting powers of attorney and anticipatory care planning that in the Yorkshire and Humber regions, rather than version 13, DNA CPRs and anticipatory care plans is all codified in respect documents that nationally NHS England is inviting us to use. We need to do regular reviews because they're under a secondary care NHS provider, so we have to look at their cluster reviews, their risk assessment reviews, section 117 aftercare reviews if they're under 117. And we try and make sure that the reviews are purposeful. So we're trying to do titration or detitration and monitoring of medication with a degree of patient-initiated follow-up. So some of it's how we need to see patients for these structured, purposeful things that the CQC expect us to do. But equally, patients will be seen frequently or less frequently, depending on their needs. And frankly, the most valued bit that patients experience from the Young Onset Dementia Service isn't so much the medical time, which is the least valued bit, or the nursing time, which is the next least valued bit. It tends to be the support, which our carers, support time recovery workers, our unqualified care staff deliver. As Mr. Booth was saying in his video, it's also the peer support. So we have patient groups doing post-diagnostic support for themselves, and that peer support is highly valued, and carer support that happens again with people relying on people, POC groups, with carer support groups that they have. We also have a very active all-age dementia charity, the Doncaster Dementia Charity, Dementia. We have a monthly all-age Doncaster Dementia Forum that is chaired not by NHS staff, but it's chaired by the leads of the Dementia charity, as well as then thinking across place how we have dementia-friendly services. So we work with things like banks where we've got cards that patients can show discreetly, it's just credit card size, saying that they've got dementia, so that the bank staff can then be speaking more slowly, more carefully, and rather than just rushing people through transactions, can manage things more sensitively. So we've thought of a range of different ways of post-diagnostic support in not just health, but across the city. In terms of how we did it, it's very much commissioner discussion. So we had a lot of commissioner discussions with the integrator when it was the PCT at the time, then the CCG, now the Integrated Care Board, the ICB, which identified service gaps because we just didn't diagnose or treat dementia in younger adults at all well in Doncaster. So we had a lot of very helpful vocal dialogue from patient groups around how this was wholly unjust, and we needed to look at resourcing a pathway of care for people in Doncaster living with young onset dementia. I'm thinking we had about 110 that we needed to find and treat, how we would have a pathway to do that, and then assess dozens of patients every year to try and pick up new patients each year that might be developing it. So it was the discussion with commissioners that has been key, and that has been the biggest learning point, really. That was us physically meeting with and having those face-to-face discussions with commissioners, then having a proof of concept where an interested nurse and a bit of my time as consultant psychiatrist developed a very small number. We were looking at literally a couple of patients a month just being seen. Evidence that it was a model that worked and delivered, to then scale it up to be able to assess literally about 1 in 1,000 of the population of the city every year and provide post-diagnostic support for them all, which then has been very helpful. We then had our patients engaging with commissioners, engaging with our local authority, We've had a high media presence that our patients have had quite rightly in charities and nationally with OBE nominations and awards. So that patient voice is central to keeping us challenged as to how we do our care as well as we should, as well as patients deserve, whilst also challenging commissioners, GPs and local authority as to how services could or should be in Doncaster. In terms of outputs, we have clinical stability, so we can show that Adam Rook's cognitive examination, Bristol activities of daily living scale, people are enjoying stability where trajectories would suggest they normally wouldn't. So we know we're keeping people well. As well as the clinical outcomes that we measure when we're looking at patient-related outcome measures, things that are relevant to patients, such as being able to stay in employment, be able to stay driving, be able to stay where they're ordinarily resident rather than moving into sheltered accommodation or care homes, with evidence that we've kept people where they want to be, doing what they want to be, for on average 18 months longer than would otherwise be the case. We've looked at performance metrics, so we are meeting the NHS England stretch target of 6 weeks from referral to treatment rather than referral to diagnosis. So we're diagnosed within about 5 weeks, treating within about diagnosed within 4 to 5 weeks, treating within 5 to 6 weeks. We've reduced hospital admission rates, both to the acute trust and to psychiatric beds through the Young Onset Dementia Service. And when you do have an admission, they've got a very much shorter length of stay than is average. The continuity of care seems to be valued by patients who like seeing the same nurse from diagnosis. Frankly, we don't discharge this diagnosis to death. So we care for people with end-of-life care in their own home or in care homes, or on hospital wards or in the hospice, and we'll move to wherever the care needs to be. We do have palliative care teams within our services here on site, and a hospice is on the same site, so we have access to the whole continuity of living well, aging well and dying well with dementia within the team. And finances, we've been shown to reduce care home placements, delay care home placements, reduce out of area placements, and therefore being cost effective in saving several £100,000 a year to health and local authority through having this service. So data, we have data for those metrics, which wasn't particularly wanted to linger on, but just those are the sources of data that we collate and report on. In terms of how we've been supported, the real challenge is the large numbers of patients that we are wanting to see every year, 150 to 200 a year. So it's having a service that does that. We're wholly NHS funded and resourced. None of this is charitable. We don't use third-party monies for the core service, because it's seen as, quite rightly, as Mr. Booth was saying, rather like cancer services, this is something that should be provided in the NHS in a timely manner, with everyone being seen, diagnosed and treated within 6 weeks, which is the ambition we're delivering on. So rather than using voluntary community paid social enterprise groups or charitable monies for the core diagnostic offer, it's felt that this is something that would be inequitable if we didn't do it through the NHS. So our commissioners consistently, as PCGs, CCGs, then ICB has been commissioning this as a necessary and effective service for people living in Doncaster. And we see it very much as having parity, as you would with people living with cancer. So we have a very active dementia research group. We have 6 people living with dementia in Doncaster who are patient research ambassadors, PRAs for research work in the Yorkshire Humber region. And we look at funding and resourcing with our local authority colleagues to ensure that people living with dementia are explicitly commissioned for. So the service that we've got is seeing people in their own home with 2 nurse assessments, then an MDT discussion and diagnosis, very much has arisen because that's what patients and families asked us to do. We originally constructed as a clinic model with a memory clinic service, but then deleted the clinical activity, moved it to home because of patient and family requests. And then happily, it has been a more effective and productive model because we've got no do not attend patients. We've looked at the role of having carers present in all our conversations. So the initial assessments are arranged at a time and a date and a place that's appropriate for the patients and the families to be, so that we can have that carer involvement. Because we don't do formal cognitive stimulation therapy, there is literally a blank sheet where we write down with the patients and carers what will be the right post-diagnostic support for you, and then think about what our peer support or our support workers or our nursing staff or other services. So we've got a lot of work happening in Doncaster in libraries and in community hubs on different groups that people can tap into that's outside of the NHS here. And then we have that monthly challenge from our Doncaster Dementia Forum. We have our staff having hopefully the right values based recruitment at interviews, because we have patients on our interview panels for staff in our teams and in our services. So whether we appoint unqualified staff or management staff or senior clinical staff like psychiatrists, we've had young onset dementia patients on all of these staff appointments. And patients and families are represented in deep dives that we've had with commissioners, so commissioners can hear their voice. So we try and ensure that patient involvement is not tokenistic or peripheral, it is core to how we deliver the service and how we review it each month, and how you're involved in ongoing work. The limitations, we are commissioned contractor, we deliver on a neurodegenerative young onset dementia service. The reality is that people want us to be a diagnostic service in kids with dementia, yes or no. So hence why we have large numbers, and we are seeing about 1 in 1,000 Doncaster residents every year, because anyone who may or may not have dementia then asking us to see, rather than it was originally a dementia service for neurodegenerative dementia, principally Alzheimer's disease. And in theory, if it was vascular and you get strokes, well, then your stroke service should see sort out the care for those people. If it's Parkinson's disease dementia, well, your Parkinson's disease service should be supporting that cohort of Doncaster residents. If it's HIV dementia, then your sexual health service should be supporting those patients. So because other services already were existing and commissioned, if you had dementia in those different disease cohorts, there should already be a service for those people. So we were commissioned because there wasn't a service for people with Alzheimer's disease as young adults. We've had people in their 20s diagnosed. So that is a gap, but we don't really have the volume of staff to deal with all of dementia. So we do focus really on the Alzheimer's disease dementia in our service. Challenge has been paced, trying to do.
John, could I just interrupt just for a moment, just to say, just got 3 or 4 minutes.
I've only got 2 more slides left, so
just we need to protect the question and answer,
yeah.
because so there's lots in the. Yeah. Thank
you. The last couple of slides. So the challenge has been paced, trying to do things quickly enough as we want, trying to have enough impact. Where there's lots of enthusiasm to do things in a number of teams, whether that's in busy clinics in the acute trust or in some of the community services, but there's often not the ability to manage the volume or speed of change that we're wanting. We still feel that people living with dementia don't get the same priority as people with cancer or physical health care problems. And there's a lot less time therefore spent on young onset dementia services compared to discussions around how busy winter planning needs to be for the acute trust through bed-based services in the acute trust, for example. And financial risk, although we have shown that we save hundreds of thousands, and it's a very cost-effective model, and for every pound spent in our service, we're saving £5 across the place. There still is a lot of concern from clinicians about throwing more money into the service when we've got deficits in budgets across our trust, the acute trust, and across the commissioning LCD. The best way for us to try and get good commissioned models with commissioners has been in part through emails, and just shunt data around, in part through presentations that can try and explain what it is you're trying to do, and in part formal papers that can show the strengths and weaknesses of different options. They were all unhelpful when we first started trying to progress service change. The most helpful way of getting a good young onset dementia service up and running was face-to-face meetings with our commissioners, because that was the only way they could get real understanding. And if it's about data and numbers, email, Teams, meet presentations, PowerPoint was fine. But for them just to get the issue and what we wanted to do and how we wanted to do it, needed that relationship of face-to-face meetings and developing a rapport with them. And just to share, we have looked at different options of other providers providing different models. So we looked at, we went down and visited colleagues in Kent. We've been over to the Wirral and colleagues in Merseyside. Had a number of meetings with colleagues in Bradford, meet up every couple of months with them. But we haven't yet, and we've had colleagues come to us from Wolverhampton, Germany, New Zealand relatively recently, but we haven't yet found a model that's perhaps more effective in terms of number of patients seen per pound or referral to diagnosis that we've been able to achieve. So we feel that we've got a good model when looking either nationally or internationally at different models of practice. Did have structure and things just to share on the slides, but that was the presentation to talk to the points that you asked to reflect upon, so we're then not time to talk things through.
Thank you so much, John. There was so much in there, wasn't there?
I noticed coming on the chat, I won't name who she is in case she's not watching to, but we do have people who have lived experience in Doncaster who are in this webinar and are potentially in future webinars better placed to talk about how things are in Doncaster and what is important for someone who's been diagnosed and is living with dementia and what they find useful from a young onset dementia service. Since I'm obviously talking about from the staff side and the commissioning and the management side, but as Mr. Bruce presented in his video, and as we've got other people with lived experience can talk more incredibly about what it is that's meaningful.
Thank you. It would be really useful to be able to get in touch with those folk afterwards, if that's okay. Can we move to questions? We've got quite a number, John. So I hope you're ready for this. We've got at least 16, I think. So, but I'm going to start with a really fast one. DNA rate. It's jargon. What is it?
But that's 2 not attend. So colleagues in York were finding about 40% of their patients don't attend their clinic because it's very rural. For us, it was about 25%. 1 in 4 don't attend their clinics. Because either through transport or business or work or whatever reasons they struggle. By not having a clinic and just seeing everyone in their own home, we made contacts much more effective and staff time much more effective. So they weren't sitting in a clinic where someone didn't turn up. Instead, every time they're seeing someone, invariably they are seeing someone. But seems a more effective model.
Okay, thank you. Are there any templates or examples of carer and patient history that are recommended for young onset dementia, as far as you know?
Short answer is no. So we looked at that, but very much no. We didn't find any specific young onset dementia models. Hence why we started with a blank sheet to look at what it, literally just get a blank sheet and go to the patients and carers. What's the right support we can provide for you?
Thank you. Can you share your timescales for CT reports? And also, do you have any exclusions for referrals into your service? And in terms of subtype, where there is some uncertainty, would you complete further investigations after CT? So three parts to that one.
But currently, CT scanning is sitting at about a month. So we normally get a referral, we get a scan at about a month. We'll see the patient at about week 4. We'll then have the NT discussion where we'll make the diagnosis or exclude the diagnosis, and then in week 5 we'll go back to them, share that news with or without a care plan. So that's the sort of timescales that we have within our service at present. And exclusion, if you're not seen to have if there's a high index of suspicion you don't have dementia, then although it's not an absolute bar, we would look at signposting elsewhere, a small approach in the first instance, because patients have asked us for that. Our pickup rate is, say, we're getting 150 to 200 referrals a year for query dementia, of which about 7 a year will have dementia. So the vast majority of assessments that we do, blessedly, they don't have dementia. We found those people with dementia in Doncaster. So you could look at that's great. We're doing a helpful service to lots of people in Doncaster. You could say that we don't have tight enough exclusion criteria, and we should be saying actually it's much more likely this person has an adjustment disorder because they've got a grief reaction and difficult bereavement, or they're stressed at work and they need support and help with that. So it might be our and I could accept that we challenge that we don't exclude enough patients, and maybe if we're trying to get it right first time and get them into the right team, rather than waiting 6 weeks for us to say, good news, you don't have dementia, but the reason you're not coping at work and finding it difficult to not concentrating, it's not dementia, let's now refer you to a community mental health team. Well, why didn't you do that 6 weeks ago? Why have you been in the dementia pathway and then going to dementia? So potentially we might be seeing too many people, but equally GPs and patients' families want to know dementia. So that's why we have a bar that's somewhat fluid to try and support the stress in the system.
Okay, thank you. A question around how long do patients diagnosed with young onset dementia receive support in order to engage with activities?
So unless the patient's wanting to opt out, we don't have a cut-off. So the expectation is, as we're saying, that we will support people from diagnosis until they don't need us anymore, which can be death. Some people, it can be as they move away from Doncaster because they want to reside near friends and family who are remote from Doncaster. But we don't have a time frame where we would be, you're in service for this time and then you discharge. It's a diagnosis. It's needs led. So whilst there's a need, which tends, it doesn't tend to disappear. So it tends to be diagnosis until then.
There was a second question around that, which I think you've probably covered, which is do people diagnosed remain open to your service and receive support on an ongoing basis? So,
unless it's not neurodegenerative, if someone has alcohol-related brain injury or Parkinson's disease or stroke damage, it is best managed in another service than they're managed in that service. But everyone with a neurodegenerative dementia stays with us.
Thank you. Please, can you discuss the level of triaging your referrals go through when thinking about those who are experiencing a functional mental health?
It's reasonably exhaustive. If I say these now, I don't know what benchmark is the trust or the base, but it feels reasonably exhaustive because we have initial telephone triage or written referrals that come to our single point of access. Then all the referrals then go through to our Young Onset Dementia Service, where Band 7 manager and Band 6 staff, nursing and social work, consult psychiatrist can then and do every we review every referral. As well as the referral information shared with us in writing, there's also a conversation with the person living with dementia, well, the person who's been referred, query living with dementia, and their family, which we're obligated to do to triage risk. So whether they've got dementia or not, if they are confused and vulnerable and potentially going to be generating risks to themselves or others, we need to be appraised of that at the point of triage. So we have three sources of information. We have the initial information that comes through invariably enlightened to our single point of access. We have a conversation with the patient, and we have a conversation with the family and carers. And then with those three bits of information, we can then triage risks and needs, and then think, does the person best fit in our service, seeing them initially, or being signposted elsewhere.
Thank you. Is the prop group that you mentioned supported by your service? If not, who runs that, please?
Hand on heart, I'm not sure. It was patients. It was the patients' carers who ran and owned it all in its entirety. Post-COVID, it kind of dwindled because they couldn't meet up in the bungalow through COVID. So it's been much more informal. It absolutely isn't run by us. So we, as in clinical staff, so nursing staff have facilitated it. So we've opened up the bungalow so that carers can meet. It was on a Monday afternoon. So we'd open it up and give them that space, and then by invitation would contribute. So if they wanted someone to talk about PIP or finances, our social worker would attend for a bit. If they wanted someone to talk about medication, I attended. If they wanted anticipatory care planning, we had nursing staff from our palliative care team attend. But although we would attend by invitation, it was the carers who owned and ran it, so they could attend to their own agenda. And it was the peer-to-peer support that was most useful, not us trying to give them answers.
Just going back to rarer types of dementia, do you deal with these cases too, in terms of frontotemporal, for example, and how do you support those?
Yes, we do. So if someone has a frontotemporal dementia, particularly if it's a neurodegenerative frontotemporal dementia, we then be supporting them with cognitive enhanced medication. Otherwise, it is pragmatic. So we're looking at what nursing input might you need, what support worker activity might you need, what social worker input might be necessary and desirable, what psychology access might you need, if there are different approaches with positive behavioural support plans and approaches to construct or generate or share, particularly with employers, since often people with frontotemporal dementia might need more input working with their employers. Particularly, we get a lot of correspondence from occupational health around what would be reasonable and proportionate interventions to support someone living with frontotemporal dementia in the workplace. So yes, they would be supported and included in our management in our service. We have one gentleman living with frontotemporal dementia for over a decade in our services.
Thank you. Is it possible to say how many people with a diagnosis are currently receiving ongoing care and monitoring?
It was 117 in February. I don't know how many it is today, but that's the ballpark. We tend to vary somewhere between about 110 and 130 on caseload between 2 full-time nurses, myself, medical input.
And I've seen in the chat whether you have an OT or OT sessions within your team, and I know you've put some details about the profile of the team within the slides, but is it possible to answer that? Okay.
No, so the core team doesn't, and that's because it was felt that we need to be inclusive, because I suppose the way our trust is constructed, we have physical healthcare services within our trust. So in Doncaster, our mental health services are, we are the NHS provider for those, but our physical healthcare services will also provide for those. So we have, I mean, literally downstairs we've got occupational therapists, therapists, our community teams. So just the way we've got our palliative care on site, community nursing on site, district nursing, diabetes specialist nurses, epilepsy nurses. So rather than having mental health OT in our core Young Onset Dementia Service team, it was felt by our own OT lead, our Band 7 OT lead, that it would be better to construct OT and physio as being inclusive from our other offers, given that they literally can just walk into the building and sort plans of care with staff or with patients, rather than OT being core to the Young Onset Dementia Service. There were briefly for about 2 years an OT in the team, and it wasn't felt that gave value to money. There wasn't enough activity for the full-time OT to be doing OT. They were ended up doing more and more mental health generic work rather than personal rehab OT. So the Band 6 OT was doing it, the Band 7 OT lead, the patients and management felt it was better to have a universal offer from our physio and OT on site rather than having them located within the team.
Okay, thank you for that. I think we'll need to make this the last question because we're virtually at the end. Curious about the focus on Alzheimer's disease and the pragmatic assessment. Does the assessment process differ if you're considering the possibility of one of the rarer dementias? Going back to that question.
Yes and no. So the diagnostic I shared was for any dementia. That's ICD-10 saying, do you have dementia? So you need to satisfy those four core criteria. And if you don't satisfy those four criteria, then the World Health Organization would suggest that you're not satisfying diagnostic criteria for dementia. So you may well have forgetfulness, you may well have mild cognitive impairment, blessedly you don't have dementia. And that's where we're pragmatic. So we have a binary yes, no. At this point in time, do you have dementia or don't you? So if you don't have dementia, it ends there. Good news, you discharge. If we're thinking, but we'll try and be helpful and supportive. So if we're thinking maybe there is something brewing, it's just that you don't yet satisfy those criteria, we would refer to neurology, because dementia and mental health services, we deal with disorders of the mind. If we're thinking there's something rare that's a disorder of the brain, well, that's what a neurologist is an expert at. So we would invite, and we would sometimes refer to neurology rather than us having a well-intentioned play at it, but sort of having a play at it when it's not our expertise in psychiatry to diagnose rare disorders of the brain. So I do joint clinics where I would physically go into the clinic with the neurologist, consultant neurologist, and we will see the patient together when we do have those rare exceptions. So we look at collaborative working with neurology to diagnose the really rare neurological disorders rather than psychiatry trying to do it and doing it.
Okay.
Colleagues.
Thank you so much. You've done a marathon session in a very short period of time. You've covered quite a lot of the questions, and in fact, gosh, we were up to 30. So you've done really well for us. Thank you so much. And I know your presentation, which will be shared in the follow-up email, is with your permission, is packed full of information. So I hope that's going to help answer some of the questions.
I think the chat, I absolutely agree that OT is highly valued, which is why it was appraised. And rather than me having a view, it really was the OT leads, the OTs themselves, the patient, the family. So, and I don't think if we had the resources, I could see that we might want to displace from poor to young onset, and then because there could be significant advantages from co-location. So I think there are different ways of managing. But I think for a different webinar in the future would be very helpful, maybe for some of our patients with lived experience to share why they think their experience of this model is good or bad, and what could be done as ambitions to do differently in the future. Since I'm mindful that we're blessed with some very vocal patients who are helpfully very vocal on the national stage to try and advocate for Young Onset Dementia Services. So could talk to us in future webinars.
Yeah, that sounds like a very good idea. Look, thank you so much. You've really packed in information for us, and really do appreciate your time on this. And it's really interesting to understand more about how your particular service model works. And just to also say to everybody that the June the 21st is our next webinar, and it's a different sort of service model, a nurse-led model coming from Northampton. So we're looking forward to that. And I've mentioned the follow-up email already, and there will be a presentation and in fact a link to register for the next webinar too. So thank you to John, and thank you to Michael and Catherine, and many thanks everyone for attending this webinar. Thank you so much.
Thank you. Cheerio for now.
Bye.